Welcome, everyone, and thank you for joining this virtual panel, Team Bundled Payments, a Playbook for Success, co-presented by our partners, Avant-Garde Health and Force Therapeutics. I am Bronwyn Spira, founder and CEO of Force Therapeutics. I'm also a physical therapist by training. I spent 22 years in clinical practice, running medical centers and private practices in the orthopedic space. And 15 years ago, decided to start a technology company, Force Therapeutics, that would help my patients prepare for and recover from surgery in a virtual medium.
Wonderful, and thank you, Bronwyn. It's great to be here with you today. I'm Porter Jones, the Chief Medical Officer at Avant-Garde Health, where we work with health systems, hospitals, and ASCs to identify opportunities for cost savings and revenue generation through a deep set of analytics and AI software that then guides that path of how to realize those opportunities. I've spent 15 years working for hospitals and with hospitals, primarily focused on value-based care, of which a big chunk of that is focusing on bundled payments and how to be successful in bundled payments. So wonderful to be here and excited for this discussion today.
Terrific. Thank you. Porter and I are so happy to be hosting two very distinguished speakers today. We're joined by Dr. Jason Simon, a sports medicine and shoulder reconstruction surgeon and the Vice Chair of Orthopedic Clinical Operations and Value-Based Care at Mass General Hospital, as well as Dr. Michael Sook, a Chief Physician Officer and Chair of the Musculoskeletal Institute and Department of Orthopedic Surgery at Geisinger Health System. And I want to thank you both so much for taking the time to join us today and for sharing your insights on the team model and what it takes to succeed in bundled payment arrangements, which I know you both had a lot of experience with. We'd also like to thank you, our audience, for making the time to join us today, and remind you that if you have any questions for us or our speakers, please submit them through the Q&A feature at the bottom of your screen, and we'll provide you with responses via email after the event. So we're going to divide today's conversation into three main sections. We'll start by introducing the team model itself. Then we'll talk about what hospitals need to actually be successful under this team model. And then we're going to get some key insights from our thought leaders today, Dr. Simon and Dr. Sook. And so before we get into the meat of the discussion, I'd love the audience to hear from our speakers themselves. So Dr. Sook, Dr. Simon, I would love you to introduce yourselves to the audience and share maybe a little bit about your experience and your esteemed careers in healthcare.
Thanks, Bron. My name is Michael Sook. I'm the Chief Physician Officer and Chair of the Musculoskeletal Institute and Department of Orthopedics at Geisinger Health System in Danville, Pennsylvania. I've been here about 13 years and had the pleasure of being involved in a lot of value-based care initiatives over the period of time with a specialty focus for myself personally in orthopedic trauma.
My name's Jay Simon. I am the Vice Chair of the Department of Orthopedic Surgery at Newton-Wellesley Hospital in Wellesley, Massachusetts. We're a hospital in the Mass General Brigham system. I'm also the Medical Director for our orthopedic specialty services, as well as our walk-in clinics and our community orthopedic group. Much like Mike, I'm very interested in value-based care and have been involved in a number of projects for the hospital and in the system, looking at value-based care and how we can improve delivery of care to patients.
Fantastic. Thank you both. So to kick us off here, let's start with a quick introduction to the team model. For a more comprehensive look into team, you can access some of the incredible in-depth resources through the Avant-Garde Health's website and also through Force Therapeutics websites. Okay, so team or transforming episode accountability model is a 5-year episode-based payment model, which will be running from January 2026 through December 2030. Team covers 5 episodes of care, which will be running for 30 days directly following surgery. The episodes are lower extremity joint replacements, including ankle replacements, surgical hip or femur fractures, spinal fusions, CABG, and major bowel procedures. Team is mandatory for hospitals in designated metropolitan areas, and these metropolitan areas cover roughly 25% of all hospitals in the US. So in longitudinal payment models like Team, Medicare has set a target price for each episode. And the target price includes all the related services during that 30-day period after surgery. At the end of each performance year, hospitals that keep their costs below the target will earn a financial bonus. And those that exceed the target will or may have to owe money back to Medicare. So another important point in Teams is that how much a hospital stands to gain or lose in the Team model depends on its performance on specific quality measures. So let's talk about those quality measures. In Team, there are 3 main quality measures, including the hospital-wide all-cause readmission and PSI 90, and those apply to all the episodes in Team. Whereas for the hip and knee replacement episodes, the quality measures also include that per PM mandate. So all those patient-reported outcome measures will apply to total joint replacements. There are also different participation tracks in Team, and these tracks have increasing levels of risk and reward as the Team model moves through its tenure. And there's one track that is reserved only for hospitals that have a safety net or rural designation. Porter, over to you.
That's wonderful. Thank you for such a great introduction, Bronwyn, to the Team program. And now that we have learned about what the Team program is, what does this really mean for the mandated hospitals? And what does it actually take to be successful under such a complex model? Luckily, we do have some historical information through participation in programs like CJR and BPCI. Force Therapeutics and Avant-Garde Health have both been extremely involved in these 2 programs and are able to utilize some of that past experience to construct a program of what it is to be successful in Teams. So we have identified 3 main components of success under the bundled payment model, or the Team model, that is coming in January of 26. First, hospitals must have a highly reliable and granular cost accounting and analytics platform that allows them to see extremely detailed information on a per procedure, per physician basis. Second, hospitals have to deploy a comprehensive digital care management solution, including automated PROMs collection. And last but not least, hospitals really must have the necessary infrastructure to validate these data points and ultimately report them to CMS, private insurers, registries, and other interested parties. So in this next section, we're going to explain each of these elements and discuss their significance in succeeding under bundled payment arrangements. So let's start with the cost accounting and analytics, which is near and dear to my heart. As I mentioned, I've been doing this for 15 years, focusing on profitability and how that affects the bottom line for hospitals, but in addition, pulling in the outcomes and quality metrics to make sure that all parties are being represented in this process. And in many large hospital systems that I have worked with or worked for, a significant portion of revenue really does come through bundled payments. But despite that, we had extremely low visibility into what was actually driving profitability at the individual procedure level. So we could actually run around, look at P&Ls from each individual service line, each individual department, and say, great, margin positive, margin negative. But beyond that, we really did not know what to do. We didn't know how to make us more positive. We didn't know how to standardize the practice. And we didn't know how to take a department that was margin negative to margin positive. We just didn't have the data or the understanding of what was going on. What even made it more difficult was the variation that we were seeing between physicians within the same exact procedure. You could have two surgeons performing the same operation, but the cost, the time spent with the patient, supply use, and the outcomes would differ significantly. And without clear and detailed data, it was almost impossible to pinpoint where that variation was. I guess the issue then comes that if you don't know your true cost per procedure and per provider, then you really just can't make any changes and you can't improve it. If you can't match cost to reimbursement, then you definitely can't participate and be successful in a risk-based model like team. But it's also not just about seeing the numbers. It's great to have dashboards. It's great to have data. But I think the crux of the matter is then what do you do with it? Hospitals have terabytes of data and it just sits there. But what do you then do with that? You need that data to tell a clear and concise story. And you need to be able to look at your cost and quality metrics and walk away with a clear set of action items. The data really needs to be your true north and guide your actions. Finally, cost variation doesn't stop just within the hospital exit doors or stop at the exit doors. Post-acute care plays a massive role in the total cost of an episode. In BPCI, we have seen the post-discharge cost ramp up and be almost 50% of what the overall spend is for that particular episode. So where you send a patient can significantly affect outcomes and readmissions, and that will impact your cost structure and your quality performance. So if you don't have visibility into how those post-acute care decisions play out, both financially and clinically, then you really are flying blind, and that is just a huge risk when participating in the team program. So with this in mind, I'd love to turn to Dr. Simon, get his experience and his thoughts, specifically around cost. So Dr. Simon, before you had access to reliable physician-level cost data, both in the OR and across the full episode, what were some of the biggest challenges your team faced in understanding and improving cost efficiency? And in addition to that, now that you have a platform that helps break this down, what are you able to do with it? And what kinds of improvements have you been able to realize, and what have you been able to see?
Porter, I appreciate the question, and I'll give you an answer that you've probably heard 1,000 times from me already. Physicians notoriously underestimate the price of high-cost items, and we overestimate the price of low-cost items. So when you think about that, if we don't have access to data, it's very difficult to appropriately identify projects and figure out what we're doing well and what we're failing at. So as we know, and I think a big portion of the conversation today is going to be looking at what value in healthcare means, and it's very simply defined as outcome over cost. So if you think about that, if we can improve outcome and decrease cost, or a combination of the two, then we are going to improve value. When you look at a program or a platform such as what Avant-Garde has supplied, it gives us access to the cost of multiple aspects of healthcare, from how much it costs us to take care of patients on the floor, to what we're spending in the OR, to how much implants cost, to how much we're spending on a cannula for an arthroscopic surgery. And when you have this data, or when you have an idea of considering data, you need to have a platform or a way to review this to figure out what your next steps are. Having these platforms, you can now come up with an idea, you can identify a cost on the dashboard, or formulate a plan, or figure out a way to address it. I think you had mentioned examples or something that we've done with this. When you look at the dashboards that we've been able to utilize in the OR, for instance, you can look at the waste of higher cost disposables that you don't realize are being used in every case. There are items that end up on the field that are never utilized but happen to be in kits, and a small item that may cost $59 across 1,000 cases during the course of a year becomes a very high ticket item. And when you look at unnecessary items or lower cost items that may be equally effective, such as a variety of bone graft alternatives, you can have a pretty significant impact on providing a decrease in cost while either improving or not affecting the outcome for our patients.
Thank you for that, Dr. Simon. Appreciate those thoughts. And at this point, I'd like to turn back to Bronwyn to get into the significance of digital care management and PROMs collection specifically for this team program.
Thank you so much, Dr. Simon, for those insights, and thank you, Porter. Really interesting insights there. I want to start here by giving a quick introduction into what digital care management and remote patient engagement is really about, and how it fits into patient-centered care and longitudinal episodic payment models. And so at its core, digital care management uses technology to enhance in-person care. And this is done by educating patients at home, coordinating their care, supporting their adherence to their care plan, and tracking their clinical outcomes. And a good digital care management tool will actually facilitate real-time patient and clinician interactions and empower patients to actively engage and manage their own health and recovery. And this is really something out of my experience with patients that I found to be really impactful, that patients had a resource to turn to during their recovery at home. And I think importantly, effective digital care standardizes the clinical surgical episode. And, we think about bolstering that pre-operative education and expectation setting, getting patients prepared for their surgery in that pre-op period, while also enhancing that post-operative recovery with engaging remote care pathways. And, Porter mentioned the cost. So this really helps hospitals get control and manage those post-acute episode costs, and at the same time deliver a high-quality care experience for patients as they're going through their recovery. In addition, digital care management can actually help stratify risk, reduce variation in outcomes and patient experience, optimize the hospital's resources and the care team's resources, and ultimately drive to improve those patient outcomes. So in the team mandate, this is really important because the mandate measures performance by tracking the cost and quality within that 30-day episode after surgery. And for the total hips and total knees, the PRO-PM is the quality measure required for those patient reported outcome measures. And the mandate says that 50% of all eligible patients, both preoperatively and at that 1 year post-op point, must report a matched set of PROMs, so that they can be compliant with not only the PRO-PM but now also the team mandate. And so what we've found with a lot of our hospital partners is that that pre-op collection may not be as challenging, but that 1 year post-op collection can be really difficult to accomplish because hospitals kind of lose touch with their patients. And so having a very integrated and engaging longitudinal system to continue to coordinate that care is very advantageous in this model. If it's one of the benefits of digital care management is that a lot of the outreach is automated. And so we make sure that those patients are reporting those outcomes and the hospitals themselves can avoid those substantial financial penalties, which in team is going to be very important on the episode basis. So a lot of really comprehensive digital tools, might include things like educational videos, remote check-ins, escalations, health tracking, virtual physical therapy, and all of these can really enhance that patient's engagement and experience with their recovery, and also help the hospital identify early warning signs in underperforming patients that aren't necessarily reaching their milestones, and then, taking an action and early intervention before that becomes a readmission or a complication. So ultimately, a good digital care partner for hospitals will lead to better prepared, better educated patients, and that can translate to shorter hospital stays, more patients being discharged home versus subacute nursing facilities. And, then in that post-acute phase, reduced readmissions complications and really managing those post-acute costs of care. So I'd love to bring in Dr. Sook here, and wondering, Dr. Sook, can you tell us a little bit about the challenges you had at Geisinger that made you seek out Force as your digital care partner, and maybe touch on how Force has helped you solve some of these issues?
Thanks, Brian. We have to go back a ways because we're engaged with Force almost a decade at this point from our early conversations. And for us initially, it was about getting some visibility and some control around our post-acute portion of our total joint episodes initially. This is before actually the advent of a lot of the bundles that were coming out. At Geisinger, we were doing some sort of what we call bundles today, long before CMS required it of people. In having both a clinical platform, a hospital platform, and an insurance platform to try to manage costs using all three levers that were the underpinning of our total joint episodes. But even still, within that type of environment, we had a hard time really understanding or getting a good picture of the costs associated with our post-acute management, and beyond that, standardizing our post-acute protocols. And so the first entry in with Force was to really take advantage of its digital therapeutics. And really, I believe we were first in the country to have Force integrated within our EMR. And so by doing that, we were able to not only understand the clinical pathways and create standardized clinical pathways, but also have that directly integrated into our EMR, which then gave us really great support to understand how patients were doing in the post episode beyond just that 2-week visit, the 6-week visit, and the 3-month visit. The other thing that I think really added to our relationship was the fact that we could do our joint classes and do our pre-optimization pathways in a much more standardized format, so that we could be personal to the physician or surgeon who's doing the case. But instead of having a labor-intensive kind of in-person joint class, we were able to scale that in a much bigger way, so that we could have people take the extra time, watch a pre-recorded video, take them through all of the expectations that they would have and we would have, frankly, of the patient during and after the surgery. And in doing so, we then link them into the digital platform, which made the transition from hospital to home much faster. And so we saw an incredible decrease in the number of referrals we were giving into the acute rehab facilities or inpatient rehab facilities, and thereby driving a lot of cost out of the total joint episode.
Fantastic. Thank you so much, Dr. Sook. And with that covered, we want to now move into discussing the importance of having a suitable reporting infrastructure. So when it comes to care quality and regulatory compliance, collecting all the required data is only half the battle. You have to also ensure that you have visibility and you can view that data in a useful format for ongoing quality improvement purposes. And then you need infrastructure to access and use that data effectively at the point of care or for care redesign. Or maybe you need that for reporting to CMS quality programs, participating in registries, And in some cases, you may use the data to actually negotiate prospective bundles or longitudinal payment rates with payers. Or, maybe you're seeking some advanced certification or Blues distinction and so on. And this can be a really heavy lift. And while some organizations may have a staff member dedicated to registry submissions and quality reporting, it's really helpful to have a streamlined process with automated data flows, pre-configured data reports, and that can really save time and reduce manual errors on the hospital staff. At Force, we actually really understand this and work closely with our care teams at the hospitals to not only format that data, but also we have dedicated clinical support teams that ensure that any applications, questions are answered in a timely manner. We manage all of those reporting requirements that may change on a regular basis. So, I think that as CMS and also private insurance increasingly is relying on quality data and cost effectiveness as a measure of value, utilizing insights from your quality metrics to negotiate with payers and ensure maximum reimbursement in the case of penalties has become an absolute necessity for hospitals. And so let me now hand it back to Porter to cover the cost angle.
Thank you, Bronwyn. Such an important aspect of being able to have this digital flow for pre and post care. I think I'd mentioned to you before, our post data collection for our patients at the hospital where I worked was fully done by a group of individuals on the phone, and it just wasn't sustainable. I don't think the patients liked that type of interaction, being peppered by phone calls day in and day out. So really appreciate the work that you and your team do. This is wonderful for the broader care of the patient and for this program, specifically at Team. And I think that just leads us into the final thought in regards to cost and quality, because one of the biggest lessons I really have learned, both in my time as a clinician and in hospital leadership, is that understanding your costs and just being so focused on costs and isolation doesn't work, and it just isn't enough. You really do need to be able to layer in quality and outcome data to make those meaningful decisions of what is best, not only for the hospital, but also the patients and the physicians that are providing the care. It's really not just about how much you are spending, but it's also about what you are getting for it. You might reduce supply costs by switching vendors or lowering inpatient costs by reducing length of stay. But unless you really know how those changes affect patient outcomes, you really could be trading short-term savings for long-term penalties, and those can come in a variety of outcomes and manner. So when you can put those pieces together, the cost and the outcomes, and then when you have clear trusted data that shows you what's driving both cost and performance, I believe that's really when you can enact change. That's when you can sit down with administrators, when you can sit down with surgeons and the clinical staff and say, here's what we are seeing. This is the variation that we're seeing. The variation is increasing the cost, and it's affecting our quality and outcomes. And now we need to know, or now we do know, how we can adjust that. And for Team, that kind of visibility becomes incredibly important. Just to reemphasize, under the Team program, you are at risk. You need to make sure that the levers you're pulling, whether that's supply standardization, case throughput, discharge disposition, or post-acute care utilization, that you are delivering not just savings, but real value. And value only exists when you pair efficiency with outcomes. It's the only way to get ahead of the curve, and really to stay ahead in these type of bundled payments is to focus on these two levers, cost and outcomes. So we'd love to hear now a bit more from Dr. Suk and Simon regarding their thoughts on team, as well as their experience with bundled payment, cost accounting, PROMs collection, and digital care. To start, what we have seen is from the data CMS has released from CJR and BPCI, we know that these initiatives have been somewhat successful, we'll say somewhat, in reducing costs. But do you think this approach CMS is taking, namely mandatory bundled payments such as team, is actually good for patients?
So, the evolution of kind of bundles from, as you point out, from CGR, BPCI into the new team format, I think is riding on the successes of driving out some waste along certain episodes of care in orthopedics, total joint replacements as an example. I think that what we have seen is that the big areas of waste, I think, once eliminated, resulted in tremendous cost reductions, which actually I think is good for the system and ultimately good for the patient, in that we didn't see declines in quality of care by eliminating certain portions in the post-acute, for example. The one concern I have is that at some point, with the high focus on cost, there's only a certain amount of margin that's left to take out before you start getting really close to the elements that are really critical for quality. And it remains to be seen, I think, for me, as to whether or not the rigid adherence to a very strict set of protocols with a very little margin for error is ultimately going to be good for patients. Because, as we know, the greater we create standardization and hold it to a very rigid degree, is the less that we take in patient variability, which actually could be a potential issue in being too rigid in this approach. I think the team model, making it mandatory, is riding on the successes of some of the voluntary processes that were put into place. And I think the signals is that some of these elements should be part of any episode of care, no matter what setting, throughout our country. But again, keeping in mind that there's a certain race that happens to the bottom, and that we have to be very careful not to fall below a certain quality threshold.
That's great. Appreciate that. Dr. Simon, what are your thoughts?
Yeah, I think Dr. Suk is spot on with this. There's a lot of opportunity with team, and I completely agree that standardization has a lot of benefits, and we can quickly realize efficiencies of scope and scale when we look at programs like this. But when it comes down to it, we're taking care of people, and when you have people, you have pretty significant variability. So as we roll out team and we start to look at the evidence-based approach and creating a system that's going to be able to take care of patients, in order for this to be successful, we're going to have to really evaluate risk stratification, making sure that patients are optimized prior to surgery. All of the education components that Dr. Suk spoke about earlier with some of the successes that he's had with the program at Geisinger, I think these are all going to benefit places such as Geisinger and Mass General, where we have programs in place and we can develop programs in place where you take a standardized approach for the masses, but you still have to be able to provide the personalized touch for all of this, because when it comes down to it, every single one of our patients is an individual, and they have different risks, different profiles, different criteria that need to be met to make their care successful.
That makes a lot of sense. And I think, leaders such as yourselves, it's great that you're thinking about these things and putting the patient at the center of the care experience. So thank you for those insights. I wondered how you all think about creating processes at your organization around the mandates. I mean, you've done it before, right? But there's always a lot of new things that I'm sure you have to put in place as you tackle compliance. And maybe you can share some examples of what you've done in the past, what's worked and what hasn't. And Dr. Suk, why don't you kick us off?
Sure. So we have a long history of working with our clinicians to help create protocols that ultimately end up with a high degree of compliance. That's through what we call our proven care methodology. And it always starts with evidence, and then it follows with transparency of data. And ultimately, when you want to create protocols around total hip or total knee surgery in the primary total hip and total knee. It's about making sure that we have the best evidence, number one. We take into account surgeon preference and variability, but that has to be backed up by evidence. And then once that's in, our work that we do with our IT infrastructure, which is Epic, which is our EMR, as we build that in so that so it's hardwired into our system. And so we don't hardwire anything unless it's clinically validated or clinically accepted first. But once that's in, then you can see that your clinical judgment is then kind of baked into your EMR, which then makes compliance very easy in many ways. And so, for example, as early on, if you set parameters around what are the so-called red or yellow flags around patient selection, if that's built in to your EMRs, you will get those notices to say, well, here I want to override or I don't want to override certain conditions, whether it's a smoking history or whether it's a question of their A1C or something like that. And then you have the opportunity to weigh in to our earlier conversation on personalization to be able to overcome standardization that is too rigid. And in doing so, it allows for physicians, clinicians, surgeons to participate in the decision-making around care, while at the same time making sure we collect the data and we stay compliant with our protocols throughout. So that baking into our system has helped us tremendously in terms of making it much easier to comply with some of the government mandates.
Well said. And what has your experience been, Dr. Simon?
So as we've been preparing for team at Mass General, we've really been focusing on changing our strategy and changing our model. So our goal is to really transition to a integrated healthcare system. So Mass General Brigham is primarily the academic medical centers of the city, and then we have our system of the sister hospitals in the community. And we've stood up really there are three major functions that we're looking at as we're developing a program and transforming the care that we're able to provide. So we have our population health service organization that is setting our organization's population health strategy across the system in line with everything to match with the risk-based value that's provided by Medicare, Mass Health, as well as our commercial payers. On top of that, we have our payer strategy and contracting team, which is negotiating all of our risk contracts to make sure that we are constantly aware and adapting to the CMS mandates, particularly what we're seeing in team. And then finally, we have our Office of the Chief Medical Officer that is setting the standard for our healthcare system overall for our quality and equity strategy. So as we're putting all of these pieces together, and as we're working more as a system, we're incorporating what we're doing at the AMCs with our community hospitals so that we have a standard approach across the system. One of the things that Dr. Sook said earlier was how they standardize across their whole platform with their pre-op education, for instance. And we are a little bit behind them right now, but this is a program that we've been working on for the past number of months. And we're working on a program very similar. We're having a standard surgical optimization program for our pre-op patients. And there's a standard optimization program for education to make sure that people are getting not only the program that they need to make them successful with their total joints, but also adding the personal touch so that there's going to be an incorporation of the particular surgeon or the hospital site that they're going to be having the procedure done in. So again, leveraging the fact that we have a very large system and we're going to provide the economies of scale, however, still providing the personalization and that touch that's necessary to make sure that each individual gets what they need.
That's great. I appreciate that. You both touched a little bit on physician engagement, and this is a long-standing discussion. And it's going to be even more prevalent as team gets rolled out. We have various shapes and sizes of physicians. We have employed physicians, physicians that are participating in gain share, community docs that really don't have any financial incentive to participate. So we wanted to really dive deep into physician engagement. How do you begin this process, and what have you seen successful in engaging the physicians around creating a consensus on these episode-specific clinical protocols, first and foremost? And Dr. Simon, why don't we why don't you kick us off on this?
Sure. Thanks, Porter. So there are a number of things to consider for this. So it's important to make sure that everybody's aligned, because without alignment, you're not going to be successful in this. And Newton-Wellesley, which is the hospital I primary practice out of, is populated by both employed physicians as well as affiliate physicians or private practice physicians who work in our facility. And our motivations are a little bit different, and our goals are a little bit different. But at the end of the day, we need to make sure that all of us are on the same page to make a program such as Team successful. Because if you take PROM, for instance, in order to be successful with PROM, you have to have an 80% match of your pre-op and your post-op patients. And when we're working with our employed physicians as well as our affiliate physicians, if we are all not working on this together, we won't hit the 80% mark. As far as a gain share model, we don't have that here. However, one way to encourage alignment is what is beneficial for not only our patients, but what can we provide for them. So in our hospital system, we have a hospital PA service, an orthopedic hospital PA service that is available for assist in the operating room. They take call overnight. They take care of our patients. They run our in-floor service, and the finances that support that program have to come from someplace. So when you take a step back and you think about all of these services that allow the physicians to appropriately care for those patients, that funding has to come from someplace, and these opportunities are what provides that funding. So if we are successful with PROMs, if we're successful with Team, and we are able to generate and recognize revenue that's able to continue to fund these programs, then we are able to provide more services to make it easier for the physicians to provide better care for their patients.
That's great. So if I'm understanding correctly, no gain share, but
Correct.
it is a necessity to have this additional funding to make sure that the affiliate physicians have the support and the infrastructure to be successful and to practice the way that they would like to practice.
Exactly. If we are successful with this, then we have the extra means to be able to provide the services that we need to continue to provide what we would like for our patients and provide an environment that our physicians and PAs would like to continue to practice in.
Great. And Dr. Sook, I'd love to hear your thoughts on this as well.
Yeah, it's a slightly different perspective when you're in a employed model. So Geisinger is a employed model, and that some 90-something+% of our docs are employed by our system. And the compliance is partly, I think, partly the right word and partly not the right word in a system like ours, in the sense that we focus largely on the things that I think drive physicians really from their kind of mission sense, and that they want high quality outcomes. And by asking them to participate early to help drive and create the right clinical characteristics around the bundle, we offer that opportunity. And then we offer them the transparency of data to see if actually those things made any difference. We don't do a gain share here specifically, in the sense that if a physician participates, they inure into their own personal income. But we do recognize that any inurement that comes back goes back to the system, which ultimately helps the larger community thrive. And so it's a little bit of a different mentality, I think, although I definitely see the value on both sides. But for us, the driving components of compliance or participation are really around focusing on the quality metrics, the participation, and their ability to take part in the development of protocols and things like that. So, a lot of times, in systems that are similar to ours, I think where things get derailed is when suddenly you're told you have to do X, Y, and Z, right? Without any input into what it was, or without any ability to change it. Here, with a very clinically driven process, whatever we come out of the back end was written and driven by the physicians. And that I think it is very helpful from an intrinsic motivation standpoint for participation. Listen, don't get me wrong. I'd love to be paid more, for participating in these things. And I'm sure my surgeons would love to too, but culturally, that's not really part of our ethos that's happening at Geisinger.
That was going to be my very brief follow-up, Dr. Cook, that I think you already mentioned. Do you think it would actually enable Team to be more successful on a hospital standpoint if the physicians had some sort of gain share, some sort of financial interest from what was gained by being on that, top 90% end of the team program.
Yeah, Porter, it's hard for me to say that for sure. I don't know how much juice you'd be able to squeeze out by importing something like that, because all of our data is transparent, meaning, pride in work becomes very clear when you are, putting on the board who's compliant and who's doing well, right? And that's part of the cost and benefit of being in our system. We all know how we're doing compared to each other. And so, I don't know if it would be, more incentive if someone was making a little bit of extra money in order to comply better or to participate better or things like that, because the system provides all of that. There's very little in the way of kind of individuality when it comes to I do my team process this way and I do it and someone else does it that way, and they result in a better outcome. And so I think in our system, I think it would have mixed results to do that. But again, I don't want to turn around and say, my docs wouldn't be interested in it, but I think the net effect of it, I think, would probably be small.
So what I'm hearing is it's system dependent. What are your thoughts, Dr. Simon?
So it's a fascinating question. Where I am currently, we do not have gain sharing, and we're using everything that I mentioned earlier. And I think with what Dr. Sook said about the transparency in data, it does really add a lot. However, if you were to rewind my career about 10 years, my first job out, I was in a place that we did have a program. We did a co-management contract, and that co-management contract was in a facility where we had one group of employed physicians and a number of groups of private practice physicians, and we were looking at making system changes such as time to the OR for hip fractures and length of stay and what implants we were using in the operating room. And by using a co-management contract, it was easier to get people in alignment for that because there was a financial incentive for people to become more engaged and participate in making the changes. And it was interesting because it was based on benchmarks, and we had to hit certain numbers with percentages for length of stay decreasing X percentage, getting down from 3 days to 2 days, or whatever the overall overarching goal was. But when we tried to do it without a co-management contract there, it was far harder to get people aligned. And once the co-management contract went into place, it was very successful. But that is a very different institution than where the two of us are now.
Again, institutional dependent. Moving on. So thank you. I think those are great insights. And value is interesting because Dr. Simon, you had started off with that value question and equation, but there's value for the hospital, there's value for the physicians that we just hit on, there's also value for the patients. And, switching a little bit to the patients now, how do you see operationally, what types of shifts or changes will there be for patients that are participating or part of that team program compared to patients that are not? How are they going to fill it? Internally, are you going to have to operationalize them different? Please give us a feel of how you see that the two pathways being different, if at all, for the patients.
I'll jump in there, Porter. We don't really differentiate between them. I mean, there's a fundamental belief that if we're going to do something and we qualitatively feel that it's the right thing to do, it'll apply to all patients, whether they're in or not. So, for example, in my 10 hospital system, team applies specifically to 2 of the hospitals that we have. For some systems, it might be, well, we've got to do something different at different places. But I will tell you that the things that we've built into place apply to all across the board. And so I think it's what set us up to be fairly successful, no matter what acronym you want to call it tomorrow, whether it's team, CGR, or BPCI. Because we pivot very quickly because all of the infrastructure is in place, including the digital infrastructure post-op, post-acute, and pre-surgical. And that also goes into all of the things that we're doing with regard to enhanced recovery after surgery, our ERS protocols, pain management, even our nutritional supplementation programs that we have involved for specifically designed around muscle recovery. And so if you're having a total joint in Lewistown Hospital, or you're having it done in Scranton, or you're having it done in the main academic center in Danville, the baseline, the foundational protocols are all the same.
That's great. Appreciate it. Dr. Simon?
I completely agree with that. I think when you're looking at a system approach, and when we're talking about the whole plan of this is to provide value and take care of patients, the goal is to address this with an evidence-based medicine approach. So if we're thinking about what is the best for the patients, if we're thinking about the best outcomes, if we're thinking about the best pathways, and when all of these roll together and also provide outcomes and value, then it's going to apply to everybody. So it doesn't matter if you're involved in a bundled plan or not involved in a bundled plan. Everybody is going or should be privy to the same preoperative surgical optimization. They should have the same access to outpatient surgery, which is potentially lower cost and has great outcomes. They should have the same access to whatever postoperative facility they're going to, be it home with health aides or whatever postoperative plan is in place for them. And the goal is to, when you look at the overall team approach, we're supposed to be providing better care for our patients, decrease our risk for readmissions, and decrease the overall cost, which is great for the system and it's great for the patients. So once you put these protocols in place, once you start to standardize and address everything so that all patients are following similar pathways with an evidence-based medicine approach, then everybody wins.
Yeah, I think that's so interesting. And, as I'm listening to both of you talk, it feels like almost that team is inching us closer to a systemness approach instead of kind of fragmented care throughout a system, which is an interesting point. But I have actually one question that maybe you all can help me with, that I've been wondering about with this team model, because they have included that 1 year pro PM, that match PROMs at 1 year in a 30-day episode. So what do you think about that? I mean, is the 1 year match PROMs an appropriate measure for a 30-day bundled episode? Or do you think, I don't know, maybe there should be different models that are looking at quality as well as cost over that 30-day period?
Ron, it's a very interesting question. There does seem to be a little bit of a mismatch, right? Because, the 1 year PROM in the way I look at it, is a way to measure long-term functional outcomes related to quality, whereas the 30-day episode is really, in my view, focused much more on cost. And I think that it seems to me that if the 30-day episode is all about the immediate post-acute care costs and complications like readmissions or skilled nursing facility stays, it may miss the longer-term outcomes that are critical for assessing the success of total joint replacements, which is the 1 year PROMs. So I recognize, I think from what you're saying, there is a little bit of a mismatch that seems to be occurring there. I think we still need to collect the data, but I think it's gonna prove out ultimately that focusing on 30 days is going to be a high focus on cost only, in my opinion. But I'll talk to CMS about that later.
Let me know what they say. What do you find?
They're looking at two different things. I think they can be incorporated and work together. But as Dr. Suk just said, the goal of PROMs is really looking at it's a match of how somebody thinks they're doing preoperatively to how they're thinking they're doing 1 year post-op. And it's really looking at patient-reported outcome measures. So was the surgery successful? How did they do? And it's going to provide us good data to really be able to look at how our providers are doing and what care level we're able to provide to our patients. When you look at the 30 days, as Dr. Suk had mentioned, it's really looking at cost and value, because the 30 days is addressing whatever has happened acutely after surgery. And the reason why a 30-day window was chosen is because anything that's going to happen that 30 days is something that is either directly related to surgery or was directly related to whatever preoperative medical issues they had that we aggravated or exacerbated with surgery. So that 30-day window is going to capture everything that is surrounding the direct perioperative episode. At a year, we're no longer looking at that, which is why I think it was excluded, because somebody who at 90 days after surgery has some sort of a diabetic problem, it may very well just be related to the fact that they had diabetes preoperatively and had nothing to do with what happened during their 30 days, which is why it's probably not getting bundled into the same 30-day window. So they're both appropriate measures, but they're looking at two completely different things.
Yeah, I agree with that. And so do you feel like, given that CMS has indicated that team is going to probably expand into more CBSAs and is possibly going to expand into additional episodes other than the 5 initial episodes, do you think this is have they kind of made their bets that this is the model for care going forward, or do you think they're still testing the waters here?
Well, I think if I could, Dr. Simon raises an important issue about, the acute 30-day episode or 30-day look back as really focusing on a very different thing, in particular on the perioperative period. To me, I would say if this is a trend that is going to be the high focus, then it really shifts, I think, our attention to very different aspects of how we deliver orthopedic care. So, for example, in the readmission space, we know that if patients have an acute exacerbation of a chronic condition that brings them back to the hospital post-acutely, right now we're not doing a wonderful job of anticipating all of that on the front end. Right? We haven't stratified patients who, we think have a higher predictability to do that. By putting us all at risk for that, I think focuses systems and hospitals and even surgeons to be able to say, where are my partners on the front side of the equation? That's a very different look than our traditional BPCI CGR look, which is focused on the cost of the post-acute, right? And so if this is the bet that CMS is making, you had asked earlier a question about, or I think Porter mentioned something about systemness, right? Or acting more like systems. And I think that's the signal that I'm picking up from this, right? Is that, if you're a community orthopedic surgeon and you're getting preoperative clearance from the private doctor in the space, now in that 30-day window, the readmission ought to be able to link back to the person who cleared the patient, right? In order to ultimately find new ways to create risk share. Systems like mine, I think, have a greater facility to try to link that back together, because if they're coming through a central clearinghouse for that type of quote unquote clearance or optimization, then you have an easier way to track it back to the right place and hopefully with data make yourselves better. The downside, of course, is that we become much more risk averse on patients who have potentially readmittable chronic conditions. Right? And does that ultimately lead to a greater restriction in who gets eligible for care? So, I think it's a great question that may be a signal for the focus of where we're going. But it certainly is very different than what we've been doing in some ways with regard to the high focus on that, prevention of an inpatient rehab facility, et cetera, which is much more directly under our control.
It also speaks a little bit to what Dr. Simon was saying earlier about that, you really leveraging that pre-op optimization opportunity for patients so that we can, manage it on the back end in a better way.
Right. Interesting thing, though, just to follow up on that, Bron, is that, as I'm thinking about it now, it's the risk profile doesn't exist on the optimization side unless you own it. Right. And so, you got to think about a scenario where, people who are in the optimization business who are not directly related to your system now being on the hook for risk. That's a whole new conversation.
Yeah. Yeah. And it speaks to why you have to have all the data at your disposal, as Porter was saying earlier, and
Right.
to make those good clinical and operational decisions. So I guess we've seen quite a few different models in the past decade or so. How do you stay ahead of these reimbursement changes and these new models coming out? And it does feel a little bit like the value goalpost keeps shifting. And so how do you think about that, with your kind of overarching administrative and clinical hats on? And let's start with Dr. Simon.
Thank you. So it's a very good question, and it's an interesting topic, particularly for two people who are in administrative roles at two very large systems. So when you have a system like MGB and you have a system like Geisinger, they are the 800-pound gorillas. I mean, there's a lot of access, all of the things that we have been talking about. If you look at the smaller hospitals that aren't attached to big academic medical centers or big systems, don't necessarily have the opportunity to be able to take advantage of the surgical optimization or the standardization or the branding of your hospital system. I'm in New England, and I know exactly what Geisinger is. I know what they've done. I know what they stand for, and I'm sure that everybody is well aware of the Mass General brand. And having names like these two big healthcare industries really give you a lot of leverage and success in an environment like this, because they're brands. These are big brands, and you can scale, and you are well known. Mass General is very well known in the greater New England area, and because of that, we are able to leverage our relationships and leverage our contracts and develop all of the relationships that we need to be successful in programs like this. When you think about the smaller hospitals that aren't attached to any of the big systems, they are probably going to have a much more difficult time adapting to a demand like this, such as team, because they don't have the resources. They don't have the system-wide standardization. They don't have the surgical optimization. They won't have the access to or necessary access to data, which is going to allow us to track as to whether or not what we're doing is successful.
Yeah, I would agree with a lot of what Dr. Simon is saying there. I think that staying ahead of the game, isn't really functionally the goal. It's really continuing to thrive with the culture of innovation, right? And as long as systems are in place, or you have leadership in place that wants to continue to push down the road of getting things better for the right reason, with the overlay of kind of a population health mentality, I think that having a combination of those two things, Jason had mentioned what they're doing at MGH in terms of his three pillars, making sure population health maintains a position with even with those acute surgical episodes, right? I think when you start to overlay the two things together, as we do at Geisinger, is I think you can't but help continue to innovate in the space, and as a result, it's a natural extension to just be ahead of the game naturally, because as mentioned, hospitals or groups that are not as flush with some of the resources that we have to continue to think about managing populations, I think are behind the eight ball when it comes to staying ahead of where team and other bundled episodes are going.
So it's fascinating, because with every program that you put in place already at Geisinger and the programs that we're putting in place right now at Mass General, they are not a response to team, but team is going to fit nicely with things that we have already begun to put in place. So the surgical optimization, which we keep coming back to, the episodes of care with the total joints, the outpatient surgery, the home health, the home hospital, all of these benefits to the patients, and standardization programs that have been developed over years for both of our systems have already put us in a position to be successful with team. So we're going to be able to respond to team being rolled out by enhancing what we're already doing. So this is sort of an extension of the care that has already been provided by both systems. It's the smaller hospitals, the smaller systems that are not doing any of this right now that are going to have to start running to catch up to where bigger systems already are, which is what team seems to be focusing on.
Yeah, and I love how both of you have kind of indicated in your answers to that question that really doing what's right for the patient is at the center of this shift. It's not responsive to a value-based care model. You know, at Geisinger, Dr. Zook's been doing the right thing for the patient for 10 years, understanding what that is. And it almost feels like, in some ways, CMS is kind of playing catch up in a way by making that kind of an institutional requirement. So I always love conversations where the patient and the best patient care is really driving change, and that seems to be the case here. And you know, on your point about the smaller community hospitals, and I'm sure Porter has been hearing this as well, they are really the ones that are struggling with this, putting things in place now, getting those operational efficiencies. It is, you know, not an easy thing to do, you know, in response to some of these requirements. And, you know, that's certainly what we're hearing from the market as well.
Following up on that, for those hospitals that aren't fortunate enough to be already on this path, give a few tidbits of advice of where to start, how to mobilize, and as physicians, what would you suggest in just getting going in preparation for team?
You know, from my standpoint, what people are oftentimes surprised with is our willingness, and I'm sure other systems' willingness to share their experiences and share even thoughts around creating protocols. And you know, I think if you know, there's a tremendous amount of sharing that occurs or that can occur in terms of getting started or at least enhancing what you already do. You know, we've done, you know, we have a number of people who continue to visit, you know, as I speak across the country, people are always asking if they can come by and see what we're doing specifically at Geisinger, and the sharing is actually pretty easy to do that. I think at the end of the day too, there is a constant reassessment of what digital tools or partners that are necessary in order to get this done. You know, Porter, you're working with Avant-Garde or Bronwyn at Force, you know, each of you play a very critical role in being a central repository for sources of truth, right? You can't do this with pen and paper anymore. And you've got to have something that's going to continue to compile data, create a sense of transparency about how you're doing or how individuals are doing, and even key performance indicators of how you're doing compared to a government bundle or something like that. And I think once you have those elements in place and then you build in the culture of kind of, you know, physician engagement, I think it's a recipe for success.
You know, at the core of all of this, all of us went into medicine to take care of patients. And medicine's a business. And we all know that. And physicians are not great at running businesses for the most part. And I think you're exactly right, Mike. The fact of the matter is that when you look at the big systems that have been successful in transforming healthcare and have at the core value of what we're doing is making sure that we take care of patients and we're providing the right care for the right person at the right place at the right time. When you put all of those things in place and you have big systems that have been able to figure out how to do it, then why not share all of this information with the other hospitals, the community hospitals, the systems in different parts of the country that may be a little bit behind where we are? And the knowledge is beneficial for everybody. You know, the end goal is to take care of people. So it's not a competition as to who can do it better right now. It's making sure that we're providing appropriate care for everybody and providing value while we do it.
I love that sentiment. because it is interesting. It is still a business, and you find there are still things that go on where nobody wants to share what they're doing, and there does not, an open collaborative spirit is not there. I have noticed it in the team program. People feel like they want to bond together, go at this together, be successful together. And I do think, as Bronwyn had mentioned, a lot of it is because the patient really is at the center of the program. It's not the money per se. It's, it really is the patient. So I think that's great. Really appreciate those thoughts. Just to finish up, let's take a quick step back, hit on this topic of innovation that everyone has been discussing in the last few minutes. In the perfect world, what else can cost accounting and digital care management do? Where can it evolve to better support you, to better support large institutions like Geisinger and Mass General, and also other institutions throughout the country that are not quite as large? Where do we need to go to be more successful and to provide more impact?
I think we're just scratching the surface with some of the data collection and the transparency that it's providing to providers and systems. Managing bundles or episodes of care is just one is probably just scratching the surface, as I said. Taking a lot of the same principles, digital healthcare management, and a stronger and much more granular cost accounting applies to almost everything else we do too, whether it's intraoperative efficiency, whether it is, finally tackling some hard answers around patient experience, right? Looking at presenteeism and absenteeism with regard to, the ultimate results of what we do surgically. So patient-reported outcomes are part of it. But ultimately, how do what we do in orthopedics affect the patient when they're involved in the workforce or they're involved in caretaking or something like that? We don't have any of that information today. As orthopedic surgeons, we believe we're making massive impact in those areas, but we don't actually know. So I think at the end of the day, the population health perspective is a relatively new one for what we do in orthopedics because we are fairly staccato in how we enter a patient's life, right? But I believe in a fundamental premise that all roads lead to ortho eventually. And as a result, we're ultimately a critical component on the quality of life and the central component of population health. So, I'm one of the few people who say that, and everyone looks at me crazy. But listen, I really believe it. We're all about the quality of life, and until we start measuring some of that in a meaningful way, in a real cost accounting way, in a real digital health way, I think we're barely touching the surface.
It's amazing because we really don't know what we don't know, and the access to all of this big data with the electronic medical records, and when you pour into something like Epic and what a company like Avant-Garde could pull out of it, it is amazing what is stored in the EMRs, and we don't even know what questions to start asking yet. And when you have a question, you can certainly find the data. And when you start going through any of the data that's provided, you can certainly start asking a lot of questions. And I think this is really just the infancy of what we're going to be able to do with all of this, this big data that we're seeing in every aspect of our lives right now. Everything we do is tracked, but in healthcare, it's amazing how much information exists that we have just barely begun to tap into to figure out what we need to next.
What is your opinion of what AI can do for healthcare as we think about the intersection of data and clinical intelligence and pathways? What do you think AI will bring to us in the future?
Yeah, so I'll jump in. I mean, for me, this world of artificial or augmented intelligence, we're at the very beginning. We're focused on so much digital tools to actually help us, make our jobs a little bit easier. So lots of it is focused on the administrative burden that a lot of us face. Things like, ambient listening technologies, that are really helpful in terms of creating, notes for our primary care colleagues. And we're involved in that here, and it's been a tremendous asset. They love it. to walk in, have a conversation, and have a note spit out. Well, I think that's incredibly important from the standpoint of making kind of the administrative burden a little bit easier. I think as a diagnostic tool, it's getting more mature, but I worry, that for some of my colleagues in radiology or pathology, right? Because, you have AI and large language models that can play a huge role in terms of crunching, not just hundreds of thousands, but millions of images and trying to identify things, in patterns, common patterns. And I think we've already seen success that they're as good or if not better than clinicians who have had certain years of practice. The next evolution of this is really in this idea of agentic stuff, right? Is having thinking companions who can help work through complex problems. I think in the world of orthopedics and orthopedic surgery, that to me is a frontier that is very exciting, right? Is how do we develop that digital partner to think about, potential solutions around surgical management, right? Beyond the, where we are today and creating protocols based on evidence and then consensus, right? But taking that personalization and having a digital partner to help work through that is pretty exciting. Whether or not, the actual physical component of robotics becomes a real factor in what we do. I don't know. I was just with a company that has a pretty interesting robot that you just press a button and it rolls into the right position for a cut. And I'm like, geez, I almost don't even need to be here for this part. And that can only get better down the road. And so I think ortho and MSK care is probably going to be later on the list for replacement, if that's really going to be the case. But I am excited about having digital partners out there. Or, even this world of digital twinning, right, is pretty interesting to me, where you take a patient's condition and a problem, and you make a digital twin and do everything you want to do to imagine what's going to come out on the back end before you even do the surgery. That's pretty cool stuff. But, maybe it'll come along after I'm gone, but we'll see.
It's interesting because, as Mike just pointed out, orthopedics is a fascinating field for so many reasons. But in what he was just talking about, everything that we have done in orthopedics over the past God knows how many years is all information and innovation and technology. When we look back on how I'm a simple sports medicine and shoulder surgeon, but the way I learned how to do an ACL 20 years ago is not the way I do it today. And the way that we were looking at knee replacements and hip replacements and even shoulder replacements for that matter has drastically changed. And as we learn more, things are changing throughout the way that we take care of patients, the tools that we use, the equipment we use, and it all is great for patient outcome and patient benefit. So over the past number of decades, all of this has been done by hand. We have people who are involved and have an idea, and they've got some sort of a mechanical background or some sort of an idea that gets played out in a cadaver lab or in a biomechanics lab, and we come up with these ideas and we try to make things work and help solve problems for our patients. I mean, the fact of the matter is we see people who have pain or who have things that are broken or torn. So how do we fix those things? Having AI and all of this technology has the potential to accelerate everything that we have been doing. It's 15 years ago or 20 years ago, we used to draw on the x-rays on a light board to figure out what cuts we were going to make for a total knee. And then you have the Mako robot, and you've got all of these models and CT scans and things that can start to figure out how we can put these implants in a model prior to surgery to see what's going to give the patient the best outcome. And with AI and 3D technology and all of the robotics that are happening now, everything is becoming so much more precise, and it's really transforming the way that we're able to deliver care to patients.
This is great. Really appreciate it. We are coming to the conclusion of today's event. Any final words that you would like to share with the audience before we wrap up?
My final words would simply be this, is that, I appreciate the opportunity to have, to talk with both of you, and appreciate the platform you're providing to think about the future of digital health and what we're doing in MSK care. I'm sure many in the audience have been thinking about this, that have joined. Really, at the end of the day, I'm pretty excited about the future of what we're going to see coming down the pike, whether it's better cost containment or better value in the ultimate picture, or a high focus on outcomes, really meaningful outcomes, and then patient experience. I think we're on a good road ahead. We just got to keep innovating.
I think that this conversation has been absolutely fascinating, and for everybody who's listening in, one thing that we've hit on a number of times is standardization and optimization and leveraging big systems. And for those of you who don't have that, for those of you who are worried about what's going to happen as a team is coming along and how you're going to manage the changes, I think that the orthopedic community and the healthcare community at a whole, or as a whole, we really need to focus on working together through these things. So you have a ton of resources through your groups and your academies and platforms like this where you can reach out with questions. You don't necessarily have to reinvent the wheel. Somebody's probably already invented it. It's just a matter of figuring out how to take the mousetrap and make it a little better, or apply it to wherever you are right now.
That's great. Dr. Sook, Dr. Simon, really appreciate your time today. I know I learned a lot, and I'm sure the audience did as well. Wanted to thank the audience for joining. Appreciate your time. And as we wrap up, please do remember to complete the post-event survey to share any thoughts, questions, or suggestions on today's event, and we'll make sure that we do get back with you promptly. And we hope that you left this panel armed with additional knowledge and insights that will help you and your organization succeed in team. So we really do hope that everyone is preparing for this endeavor and has a wonderful journey through team, both for the patients, the hospitals, and the physicians. So thanks again. Hope everyone has a great day, and we'll see you soon. Thank you.
Thanks so much, everyone.
Thank you.
Thanks for having us.